I have the pleasure this afternoon of welcoming Jos de Blok and Ninka Hoegeland from the Netherlands. It's been an eventful journey, I think, but they've both arrived and we're very pleased to see them here. So just to say a little bit about Jos. Jos is the founder and the CEO of the Buurtzorg Neighbourhood Nursing Team. It's 10 years in next Christmas, Jos, since the company was founded. And I think it's safe to say it's absolutely revolutionised community nursing in Holland. In fact, it's gone global. Talking to Jos now, it's in Canada, it's in America, Sweden, it's taking off. There's interest in England, and we have a pilot site running in South Leeds. So we're really pleased. I had the opportunity to go over to Amsterdam and see Buurtzorg in action. And one of the key things which resonated with me was the empowerment of nursing. Jos said it's about removing the silliness and allowing nurses to do what they do best and care. And I think we will hear after Jos from Ninka about a case study about what it means to be a Buurtzorg nurse in reality. So Jos is a nurse by education, and he's considered a change agent in the Netherlands when it comes to organisation of home care. Before he established home care, Jos had several senior management positions in home care organisations, including Director of Innovations for Medical Services. But I do warn you, if you try to follow him on Twitter, make sure your Dutch is up to speed. So over to Jos.
Okay, thank you. Thank you. Yes, thank you. I'm happy I made it because I missed my plane this morning. So, and then it looked like there was not another plane anymore, but there was one at 3 o'clock. So I'm sorry I missed the other presentations because I was looking forward to this day, but I will hear from perhaps during the drinks how the day was. I want to tell you a bit of my history and the journey we went through in Holland. And as already been said, I'm a nurse by education, but before that I studied economics. And I didn't really like the study. I liked economics, I still like it, but the world of money is not my world. So I became no economist. So I was really talented, and still my controller at Buurtzorg, he always is amazed that I know everything about the financials. So I said and it's very helpful because I think nurses should also understand the financials. I was educated as a hospital nurse and worked between 1981 and 1986 as a nurse in different hospitals, a small one. I started in a very small hospital where you have to do everything. And I think I learned a lot there. I remember still the night shifts where you had the most amazing things. So it was for practice as a nurse, I think the most ideal environment. And after that I worked in an academical hospital. And also there I learned a lot. But when I became community health nurse, I thought this is the most beautiful profession there is. So I was responsible for a neighborhood, worked together with other colleagues who I think were very well educated and had a very strong position in the neighborhood. And that was, I think, amazing to see. Then I got a little bit frustrated because of the changes in Holland, and you see it all over the world, that the healthcare became more and more bureaucratic. So more rules, regulations, more task, fragmentation, and so on. So when I became innovator, I had done a study for that, and I thought perhaps I can change it from inside out. And then they asked me to become a manager, director, because I had so many ideas that I said, perhaps in this role you can do something. And some of this I liked, but a lot of things I saw that in this organizational development, the organization became bigger and bigger and merged with other organizations. And it became more and more difficult to deliver the care the way I thought it should be delivered. So then I resigned together with some friends, so and my wife. So we said, because we were working at the same place, and then we said, let's try something different. And that's what I want to share with you, what the difference is with what was the current policy in Holland and what the world is now in community care. I also wanted to share my experiences with the end of life, because I think it's also giving me the inspiration to do what I am doing now. In 1967, I still remember that my father came home and my mother was going to the hospital because he had the birth of our youngest brother, and my youngest brother died by birth. And my father said, when we asked, we were with 5 children, we asked, what is it? What do we have, a brother or a sister? And he said, it's a brother, but it's an angel. So, and we didn't really understand what he was saying, and we were very angry that we didn't have this brother. But what I remembered was that my mother was in the hospital, and there was a nurse who was taking care for her, and my mother said, I want to have this baby with me in my bed. And usually in that period, it was normal that they took the baby away from you, because that was normal in that period. But this nurse, she said no. She took the baby, and my mother said, I still remember, she's now 80 years old, that in this period I stayed with 2-3 hours with my son, and that was for me the best way to mourn and to give it a place. So, and that's still how she talks about it, that she's very grateful for this nurse, that she felt at that moment that this was the most important thing she could do. And then from 1968 to 1973, I was a servant in the Catholic Church, and I became a funeral expert. Because, yes, they didn't like me so much at school, so they said if there was a funeral, just go to the church, then you are not bothering the teacher. Yes, and that stayed all the rest of my life. But I was always looking into the church when these funerals were going on, and then I was 12, 13 years old, and I was thinking, what are these people thinking? What happens when people die? So what happens in these families? And I had young people, I had old people who were dying, and in that period I started to think about what's the meaning of life. So. And between 1973 and 1980, I got a growing awareness on existential issues. I read philosophers, Sartre, and I thought, how are we dealing with each other in society? And are we taking care for each other, or are we sending people away? Right? It's a very actual discussion with all the refugees. Are we open for people in need, or are we just saying, oh no, it's only for us? So stay away from our country. Between 1981 and 1995, I did a lot of palliative care as a nurse in the hospital and in the community. And I don't know if you have the same feeling, but for me, they're all little movies in my head. So you build something with the family, you come there 2-3 months, and if you're doing these things right, then everything says, this is the best possible thing we could have done. So, and then you come afterwards to the relatives and they say, oh, it's sad that our father or our mother has died, but we have such a good feeling that we all together have done the best possible things. For me, when I saw this home care organizations growing in Holland, I got quite frustrated by that this was more and more difficult to do. So because we had a very task-oriented way of doing things in these years after 1995. So now I try to use this inspiration to facilitate palliative terminal care. Nienke will tell how she experiences in daily practice. It's a beautiful team as she's working, and she's also working in a hospice. But it's better that she's telling herself. My idea is that we should collaborate with volunteers. We should create a vision on end of life of care. That should be the main purpose, I think, also from a health organization. How do we deal with vulnerable patients? And I think one of the important things I developed during my life, that everyone should be able to decide on how the end of life should be. So that's a current discussion in Holland. There are a lot of programs on that. One is called Over My Dead Body. That's about young people who are terminally ill, who have cancer, and they follow them in their last months of the last year of their lives, and how they think about how life is in this period and how they think about their own death. So these were some important reasons to start an organization where you could deliver holistic care, where you don't have to worry about all the tasks, what you can do or can't do, just create the best possible environment. We started with one team with 4 nurses in 2007. So I started to work again as a nurse in that period. And at the moment, we have 9,700 nurses in 850 independent teams. We have only 45 staff at the head office. We don't have management, and we have 15 coaches. So coaches are supporting teams when the teams need support. But a lot of teams don't need support, they can't support themselves. There are no managers, no leaders, also not in the teams, and they're just organizing the care in the neighborhood themselves. And at the moment, we take care for 70,000 patients a year, and a lot of them are terminally ill. If you look at the policy in home care till 2006, as I already said, you saw a fragmentation on cure care and prevention. You had a standardization on care activities, so you had someone for washing, someone for taking care of the wound, someone for the pain management, and were also organized also in different teams, and it's also the payment system was organized by that. So we had, for example, we had 12 products. One was nursing care special, nursing care extra. You can't imagine that people develop these kind of things. And we had personal care extra special. You had guidance extra. I think Nienke still remembers. Eh? And then you have all these codes. You have to think about all these codes. How many minutes did you spend on this and that activity? It was terrible, really. And the assumption was, in the 80s, 90s, when this all was developed, that the quality would go up and the costs would go down, because it was a professional way of organizing. And it was what I saw in all these years was that the opposite happened. The quality went down, the education level went down, so there were more and more lower educated care workers were doing the nursing activities, in my opinion. And a lot of patients got confronted with a lot of different nurses or care workers. Sometimes they had 30, 40 different people per month coming at their home. So how can you build a trustful relationship with so many people? At that moment, there was also some prognosis on the capacity problems because of the demographics. If you look at the coming 20 years, if we would go on this way, we had a big problem with the costs, but not only with the costs, we don't have enough nurses to do all the work if we organize it this way. And if you look at the way we were monitoring what we were doing, it was only about the hours and about the money. So it was just monitoring hours, and what the result was of what we're doing was not monitored. So we didn't have any information about outcome. And I think, I thought if we show outcome as nurses, then we build a better standard for the future. If you look at the development of costs in the Netherlands, then you see that the last 10 years, 15 years, it's quite dramatic. And I think it's because of the way we are organizing the payment system. This is about reform in the long-term care at the moment. We had a lot of changes the last few years. And I was, last week I was with the Minister of Health in China, in Shanghai. And in Shanghai, it was very nice to hear him talk about buurtzorg, because he said, buurtzorg has been one of the most important pillars in my current policy. And he was saying that to some Shanghainese mayors. So, and now they want us to have buurtzorg in Shanghai. So you can look at the sheet to find out more about the reform, but it's not really very interesting. What we tried to do in 2007 is to go back to the principles of the primary healthcare from the World Health Organization. So I don't know if you know, but 1986, there was a very good model developed by the World Health Organization on community-based integrated care. So we took these principles and also the principles I worked with myself as a community health nurse. And the idea was, if we create small teams in the neighborhood with high-skilled nurses, they can organize everything themselves. They can take care for all type of patients, and you don't need management to support that. So that was the idea, and from the start we got a lot of response from all over the country. So nurses said, in Amsterdam, for example, they said, oh, we have heard about this, can we also start a team? And then we had a meeting, and then during the meeting we talked about what is nursing about? How should we act as nurses? What is important for us? So, and then at the end of the evening, usually they said, when can we start? So they said, just think about it, because it's a big step to resign, because a lot of these nurses just worked for many years at the same organization and didn't resign before. So when it was just in the beginning, taking a risk that you didn't know this was going the right direction. But the idea was that if we were focusing on the networks in the neighborhoods and focusing on the GP again, because we used to work very closely with GP social workers, and starting again doing that and trying to build informal relations, that it would go the right way. This is our vision. We say we should support independence. So the payment system we had in Holland led to a lot of depending people. So when you are taking care for people, it always sounds good, but you also can damage people by taking care of them. So usually they don't know what to expect. So they just expect that they can trust on you who's coming at the house. But when selling hours is the motive, and that became the motive for a lot of organizations, then I think it's damaging the independence. So what we say is, we are part of a community, we are part of a network, and we have to find connections with the informal care, with all the formal caregivers in the community, and we use these resources when we think it's necessary. So like volunteers, we have a lot of people who want to do something for other people, but we just need to ask them and connect them with the people who need this. So this was the idea, working with the focus on empowering, adaptive, creating networks, and support people. At the same time, in all these organizations I worked, I was very critical about the hierarchy. So I became manager, and before I became manager, I had an idea that all the managers were taking decisions based on wise things and on knowledge. But what I saw was the opposite. So what I saw was just that the management itself created an own world where a lot of things from the daily practice got lost. So vision meetings and strategies and all kinds of important things led to worse and worse conditions for nurses to work in. That was my perception from 1996 to 2006. In these 10 years, I learned a lot. So they asked me to become director innovation, and I was also responsible for the medical service of the nursing homes. and also was very critical on the nursing homes because I said, you are talking too much with each other, in my opinion, and not enough with the patients and not enough with the families. So the focus in the management and the focus on the different disciplines was too much on the organization and too much on each other. So we said, if we change that, if we say, okay, nurses should focus on the patient, then we need another way of organizing. So then we don't need all this management, because the nurses need to decide themselves on what they see and how they can deal with the things they are meeting in their daily work. And it should be based on trust. So you can trust nurses that they're doing the right things. I don't know any nurses who say, okay, today I'm going to do terrible things with my patients. But perhaps it's special in Holland. Yes, that's true. I said it a few weeks ago to someone who asked me about the NHS. I had a meeting 4 years ago in London, and it was one of the bosses of the NHS, and we had a dinner in one of the hotels, and he said, in England, the nurses don't really know what patients need. So I said, is that true? So then we started the discussion, because I said, I think that you created an environment as NHS where it's more and more difficult for nurses to do what they think they should do. And okay, he was not really amused at the end of the evening, but that was no problem. No, you meet a lot of people who are not amused by what you're doing if you're doing things differently. But that's not the problem. It's about the patients, and it's about the relation with the patients. So what we did was creating teams with up to 12 nurses per team, who are dealing with 40 to 50 patients. And we also started an IT company. We said we want to support the nurses in a way that they feel they can do their work better than without the ICT. And a lot of ICT is usually developed for administration. Then we said we want the nurses to be generalists, just to be able to take care for all types of patients. That gives a lot of variety to your work. And 70% of our teams are based on registered nurses. They have their own education budget. They decide on their own education because they know themselves best what they're good at and what they should learn. So if they meet more problems on, for example, mental care or palliative terminal care, they can decide to do an education on that. We say informal networks are much more important than formal organizational structures, so try to avoid all kind of contracts with other organizations. Try to develop informal relations, friendly, respectful relations, meaningful relations with, for example, GPs. When you have the feeling that you're dealing with the same things and you can find each other very easily, then it's much stronger than it's based on a contract. That's my opinion. So we try to avoid that. And we supported teams with a training on solution interaction methods. So the idea is focus on solutions. Try not to spend too much time on analyzing the problem. Try to find how you can solve things when you have some problems. And then you get these kind of teams, so quite happy, and these kind of patients. She's 105 now, living in Rotterdam. Tough mother. These are the different types of clients we are taking care of. Especially what we say is palliative terminal care is for most of the nurses very, very important. So they always say, sometimes we can't handle all the patients, but we will always make space for the palliative terminal care. We also take care for chronically ill people, people with dementia, people who are discharged from hospital. So I think but perhaps Nienke can say it, but I think we can take care for 98% of all the patients we have in the community.
Yes.
Huh?
Yeah.
If you look at hospice care at Buurtzorg, then it's around, I think, 20% of all the patients. So every nurse has to deal every day with palliative terminal care. We work very closely together with the GPs. For example, on the on the pain management. If you see you come in the evening and say, okay, I think we need some more, shall I phone the doctor? Usually the doctor thinks it's right to call me when it's necessary. So that's, we also work together with the OT and PT, and also we have a strong relation with the volunteers. We have in Holland a very good organized voluntary organization on palliative terminal care. And you build another relation with volunteers than with professionals. So what you see is that often the volunteers keep a relationship also after persons have died. So that's, I think, very important to think about creating formal, informal networks. The community health nurses assess what's necessary. That became legally now the role of the nurse. So up till last year, we had an assessment institute who did the assessments, and then they decided on how many hours you could spend. But based on our experience, the minister decided that it was again the role and the authority of the nurse to do this. We have a lot of discussions on euthanasia. We have a long history on this issue in Holland, and I think it's very good to have an open discussion. A few weeks ago, before I went to China, I was in Taiwan, and there were some people from Japan, and they started also the discussion in Japan. And it's a very difficult discussion because in Japan it's more that the family decides on what should happen to someone who is at the end of life. So I think it's good to think about how we can regulate it in a very proper way. We are developing hospices ourselves when people can't stay at home, and we're working in existing hospices. I think the nurses are trying to create the optimal environment for patients. What I already said, informal and formal care, good combination, medical, social, and also the spiritual needs. So we have regions where different religions are still very strong. So then you connect with the church and you also involve them in the care. And I always say you can only one chance to do it. You have only one chance to do it right. So I think we should focus on how do we do it at the end of life care as good as possible. We started when we developed Buurtzorg, we say the current quality systems are not really very helpful. So the ISO systems, they're good for the organization, but not good for the patient. Or they're even not good for the organization, I think. So we introduced the OMAHA system. That's a classification system of problems, interventions, and outcome. And based on this OMAHA system, we develop guidelines and standards. So, and we also integrate them in our system, in our IT system, so that all the nurses can see what are the good practices on different patient groups. We take the role and activities as most important element of the quality system, and we say, okay, the education level is very important. Try to focus on high education level, and the average in Holland, every home care organization is working with 10% registered nurses, and we say a lot of our work is quite complex. We should focus on higher educated nurses, and we measure the client satisfaction every year. If you look at the organization, then a lot of people don't really understand how it's possible to have almost 10,000 nurses without a management system. But we don't have a management team. I started this together with my wife, and she's doing the back office. So, and we never have management meetings. So we only sit together when there is something to discuss. But we never made agendas, or we never made minutes up till now. These people at the back office, we have now 315 million euro turnover per year, but we don't have a CFO. So I said I studied economics 2 years, and that's enough to understand all the financial things. So we take care for the bureaucracy in the head office, and we try to support teams in a way that they're not bothered with all the administrative things. As I said, we also started an IT company, and that became quite a critical element of what we are doing. So it was in the period that Facebook started, or was exploding, I could say. So we created our own Facebook, and now a lot of knowledge is shared by the nurses on the web. They put articles on it. There's a learning environment, and they do the administration on the web. And what we try to do now is to also experiments with hospitals, with doctors, and also with clients to connect them with our web. So it's, especially the clients, it's really exciting to see what happens because we created a client portal and they're now connected to the team so they can also discuss with the teams how they want the things delivered. These are some aspects from the Buurtzorg web. What I noticed was that writing strategy notes and policy notes is quite useless to do. So if you're working in an organization and you're spending your time on these things, try to stop for a while and see what happens. Because no one is missing it, really. We're doing a lot. Yes, I was amazed because that was one of my most important things in my jobs before. I did one project after another. And since I didn't do it anymore, nothing really happens. A lot of things happen, but it comes all from bottom up. So try to avoid things from top down, and the great things will happen. I write my blog now. Yeah, every few weeks I write a blog. I should write more blogs, sometimes I hear. But then I get a lot of comments on these blogs, and then we say when a lot of comments are going the same direction, then we say, okay, this is our new policy. So that's how we use the web. And it's also, it's used for shared values. The nurses, they work in all different teams all over the country, but they feel connected by the web. And also we have a lot of conferences and a lot of meetings. There was a National Sporting Day every year. And then you see 1,500 nurses sporting and having a very nice day. Okay, one of the important things is also organizing parties. So that's, this is how it's grown from, or the figures, sometimes I forget to adjust the figures. It's every time again, it's changing. We're all over the country, and I think last year we said, okay, we have to be a little bit careful because of the changes in the system. But the growth was again 45 million euro. So it was without doing anything. We don't do marketing. It's just all based on publicity, free publicity. There are some people who are writing about us, and if you are interested, I could advise these two books. Frédéric Laloux writes about the organizational perspective, and Shada Nandram, she developed her own theory based on our way of working, and it's called the integrating simplification theory. So a lot of people in the world want to make things more complex, and we want to make things more simple. And when things are more simple, then you can oversee everything, and then you can take responsibility, accountability, and then you can decide on everything you're doing in your daily life, just like home. So we create a home-like environment. She mentioned 3 principles. The needing principle, do what's needed, so don't do what's not needed. And that's about the silliness. We do a lot of silly things. So if you're doing silly things, just quit with doing silly things. Gives you a lot of time. Then the rethinking principle. As nurses, we are very good in reflecting on what we are doing. So let's keep on doing that and do that with your colleagues and try to create the best possible practice. And then the common sense principle. And in the world of nurses, I think the common sense principle is very normal.